So Dr. Rajesh will be talking on prophylaxis of post-op endophthalmitis. Over to you, sir.
Thank you very much. A very good morning to all of you. Endophthalmitis is one of the dreaded situations, complications that can happen in a case of cataract, and we would never want to have it in our case. So we do take preoperative and intraoperative and postoperative measures in order to prevent endophthalmitis. Starting with the preoperative measures, one important thing is that if somebody is a diabetic, then the blood sugar control should be good. Otherwise, the risk of post-op reaction is high. The risk of flaring up of any subclinical infection is very high, and that can result in endophthalmitis. Of course, we should check that there is no regurgitation on pressure of lacrimal sac, and there is no discharge, there is no, and one should not do any contact procedure like biometry or tonometry on day of surgery. If there is definite redness in the eye on the day of surgery, if the patient has come to you and you see that the eye is red, chemosed and all that, then it should be avoided. And preoperative topical antibiotics, a lot of people give. There are indications, there are definite suggestions also in literature which states about the role of preoperative antibiotics. But of course, the biggest role is of povidone iodine before the surgery. If that should definitely be put in the eye before, or first of all you should clean the lashes and eyelid, and then of course you should put it inside the eye. As far as intraoperative measures is concerned, we should have adequate OT sterilization. The proper OT should be there. It should be sprayed, and OT sterilization should be maintained. A regular culture should be sent from the OT so that you are sure that there is no organism growing in the operation theatre. Sterilization of instruments should be adequately done. And I'm not going into details of all these because each topic in itself is a single talk. So I'm just covering up the basic heads. And of course, there are monitors which will tell you that the instruments are properly sterilized, and this is always there. You can use disposable instruments, which is something which can be of great use. A lot of companies are coming up with disposable, irrigation aspiration probes and blades, etc. And that does not, that takes away your headache of sterilizing the instruments. Anything that goes inside the eye, like phagotape, sleeve, cannula, should be changed for each case. Adequate hand washing should be done. If you're using betadine or chlorhexidine, then it should be, scrubbing should be done for 3 minutes. If you're using liquid soap, at least for 5 minutes. And bar soap should be avoided, and water should be clean. And proper gowning and gloving should be done. There is a proper etiquette for that as well. I'm not going into it, but yes, the gown should be properly sterilized, and mask should cover the nose. Sometimes you see that people have their mask coming down, which is not acceptable. It should cover the nose and mouth properly. The OT cap should cover the hair completely. There shouldn't be hair coming out of the OT cap. That's very important. And the position of the hands after scrubbing and gloving should be above the waist. And the patient hygiene should also be maintained. Patients should be told to clean their hands, face, and then of course betadine cleaning with 10% betadine should be done of the lid, lashes, etc. And then once that is done, when the patient is on the table, you should put 5% betadine in the eye. It is very essential to understand this thing because many times we get the supply of 10% betadine. We should dilute it to 5%, otherwise it does cause some surface toxicity, 10% betadine. So when we are instilling into the eye, it should be 5% betadine, and it should be kept for 1 minute. Sometimes in some of the countries like in UK, even double contact with betadine is done in order to prevent endophthalmitis, and it has a definite role. Of course, the irrigating bottles should be separate for each patient. That is very essential. You should always keep a sample of the bottles of that batch that has been used, because if there is any infection that has happened, you can send that that fluid for culture, and that can save you, because if there is anything wrong in the bottle, then you can always say that in the court of law that it was not exactly the surgeon's fault, it has come from the company. So that is also something that will safeguard your interest. And of course, intracameral antibiotics, which has become very popular these days, it should be used at the end of the procedure. So once you hydrate the wound, hydrate the main wound, and the side port as well, after that you inject into the bag. You try to push it towards the IOL so that the intracameral antibiotic remains. And which intracameral antibiotic, that is an important thing, important issue. Intracameral moxifloxacin has now become very popular, and it is used worldwide because of earlier we were using vancomycin. So this is how we just push it fast so that it goes in towards the bag, and that is the end of it. So earlier we used to use this vancomycin, but then there were reports of necrotizing retinitis and all those things, so that's why vancomycin is no more used. This is a very good study done from our own, from India, by Arvind Eye Hospital, and this is analysis of 6 lakh surgeries, wherein half of them were injected intracameral moxifloxacin, 0.5%, 0.1 ml. That is important. 0.1 ml of 0.5%. And half of them were not injected moxifloxacin. And they found out that there was a significantly lesser chance of endophthalmitis, occurrence of endophthalmitis in eyes wherein intracameral antibiotics were given. So they found out that the overall endophthalmitis rate reduced by 3.5 folds, 3 folds for manual SICS and nearly 6 folds for phacoemulsification. And they also saw that in cases where there were PCRs, posterior capsular tears, in such cases, wherever intracameral moxifloxacin was given, there was much more reduction in the chance of endophthalmitis, and that is why the study strongly recommended that intracameral moxifloxacin should be given in eyes wherein there is a PCR, and of course, it should be given in all the eyes because it reduces the chance of endophthalmitis. Well, there are people who are still not giving worldwide, but that is a different issue altogether. But if these things have come in literature, and if you don't put intracameral moxifloxacin, then in a court of law, if there is an endophthalmitis, then if you have put it, then that will be an extra safeguard for you. You can always say that yes, we have followed all the norms that are there in the literature. And as I said that, intracameral vancomycin, which was used earlier in the fluid, there were reports of hemorrhagic occlusive retinal vasculitis, and that is why now intracameral moxifloxacin is being used. This is another study which has shown that intracameral moxifloxacin is non-toxic and safe, but the dosage should be 0.1 ml, 0.5% solution. Now, this is the ACRS clinical alert. And it was an advisory that was released, and it was published in the year 2023 in JCRS. It has been done by a good friend of mine, William Myers, of course, in association with a big shot of cataract surgery, Dr. David Chang. And they did this advisory because they found out that moxifloxacin is being increasingly used, and there are 2 different concentrations available, 0.5% and 0.1%. So what should be the dose? Because if you inject more, then there is risk of TAS. If you inject less, then then it is ineffective. And that is what they did. And they finally published the report in the JCRS in the year 2023. And they reported that 0.1 ml of compounded moxifloxacin, 0.5% solution, or they had used Vigamox, and or you can inject 0.5 ml of a compounded moxifloxacin, 0.1% solution. Whatever you use, it should be either 1 ml of 0.5% or 0.5 ml of 0.1%. Because if you increase more, if you inject more, you can have TAS. And any additives, if they are there in the formulation, then that can also cause TAS. And this is one report which has reported occurrence of TAS, and they reported that it was because of the installation of higher volume, that is 0.6 cc of 0.5% moxifloxacin. Another study showing efficacy of moxifloxacin in preventing endophthalmitis. And of course, in the end, wound security is very important, so we should have a watertight wound. And in case you see that there is any leaking wound, then in that case, don't hesitate to put suture. So in conclusion, endophthalmitis definitely is on decline. Long time back, we used to know that it was 0.1%, then it reduced to 0.2%. Now it has come down to 0.07%, and it is all because of all the measures that we are taking. Of course, intracameral moxifloxacin is a very important tool, very important step to prevent endophthalmitis. But the most important thing, once again, I would emphasize, is use of povidone iodine in cul-de-sac before the surgery. That is again a very important step. So thank you very much for your patient listening.
Thank you, sir. So what is your take on pre-op syringing?
Sorry?
Preoperative syringing, sac syringing.
See, if there is no discharge and if there is no regurgitation, Roplast negative, then there's no need to do syringing in all the cases. Only if there is watering or a little bit of discharge, if you have some doubt, then only there is need of syringing. Otherwise, it should not be done.
Even for one-eyed patients?
Even in one-eyed patient, if there is no discharge, no watering, nothing, then there's no need to do syringing. Roplast negativity is something which is a very important step. Yeah.
I think very nicely expressed the emphasis given on the use of intracameral moxifloxacin, because there is always a confusion. People use various regimes. Some use topical antibiotics few days before surgery. Some use topical antibiotics 2 hours before the surgery, very frequent dosing. But it has been published that if you give pre-operative antibiotic topical drops, the concentration achieved in anterior chamber is just 2 microgram per ml. Whereas if you give intracameral moxifloxacin, as very nicely explained by Professor Rajesh Sinha, you achieve concentration, intracameral concentration of 950 microgram per ml, which is more than 10 times the minimum inhibitory concentration, because you want to retain this concentration for 4 hours after the surgery with half-life of about 4 hours. So this is well established, and all these guidelines, ASCRS guidelines, ESCRS guidelines, now there is a SAGAR guideline by Australia also, which has clearly established that the intracameral moxifloxacin should not be given in high-risk patients, that is one-eyed or having PCR, but it should be routinely given in all your cataract patients. And this has been nicely emphasized in the study by Haripriya et al. In JCRS, who has done study on consecutive 6 lakh patients. I think very nicely